So I'm delighted to be able to share the results of my study with you, and I'll explain all about it and how it was conducted. But just before I get started, it wouldn't make any sense, I don't think, unless I gave you a few minutes about the history of breastfeeding in Ireland and sort of where we've come from. So, may not share there. In the Western world, breastfeeding was nearly lost altogether. In the 70s, the US only recorded about 25% breastfeeding initiation rates. We weren't really recording them in other countries, but some Irish hospitals had any breastfeeding at all, as low as 10% in the 70s. So we started doing national statistics in 1984, and by 1994, we started with our first national breastfeeding policy, which some of you who've been in the breastfeeding field a long time may recognize the pink lady up there in the top left corner. And we've had several policies since. We had very high ambitions. We set great targets and we often didn't reach them and had to come back and come up with new targets. So we've been doing that for the past 30 years or so, and we now have our national standards for infant feeding since 2002. It's probably no surprise to anybody who is working in the lactation field or familiar with breastfeeding where we stand compared with the rest of the Western countries. We come right at the bottom. So sadly, we have the dubious distinction of having the lowest breastfeeding initiation rates in probably the developed world. The only ones we don't have are countries where they don't collect breastfeeding rates routinely. What's really concerning, though, is not only is it 62.3 initiation, by 2 or 3 days after birth, a huge chunk of these mothers who started out breastfeeding have already introduced formula or have given up breastfeeding altogether because the discharge rate drops dramatically. It's either 36.7 or 44.5, depending on which data set you go by, but they're the latest statistics we have. I think there are new statistics coming soon, but they're for 2020. So they have gone quite low. So where does laid back breastfeeding fit into all of this? Well, it might be able to help in that early days, in those first 2 to 3 days when breastfeeding is trying to be established. Laid back breastfeeding, I introduced this topic at one of our, when we were talking about research we were doing, and one of the other students paused and she said, laid back, so do you mean like the position you're using, or do you mean like chill? And I said, that's perfect. That's exactly what I'm going to use, because it should be both. It should be chill. It should be relaxed, as you see the mothers in these photographs, very relaxed feeding their babies, but it's also the position they're using. So basically, if you were to describe it, laid back breastfeeding is a position whereby instead of a mother's arms supporting the weight of the baby, it's her torso that supports the weight of the baby. So she can recline back very slightly in an upright chair, as you'll see the lady on the left doing. She's in a cafe in London. Her baby's a little bit older. Or you can lie a good bit farther back. You could be in a bed, a sofa, an armchair. The furniture doesn't matter. The age of the baby doesn't matter. The size of the mother doesn't matter. And that's why I wanted to use a variety of photographs here, because one of the things in the survey was some midwives felt mothers who had a high BMI, it wasn't suitable for them. But it's just about tweaking and knowing how to adjust the body, adjust the baby, and adjust the breast until you get that fit. It doesn't mean it can't be done. And we now have very good studies that have shown that laid back breastfeeding actually is hugely helpful in reducing nipple pain and soreness by up to 50% or more, almost eliminating mastitis, encouraging a better and deeper latch for babies, and encouraging better milk transfer. And it even shows that babies who are feeding in this position are less likely to lose as much weight. And when you think about it, that makes total sense, because if a mother's less sore, if she's not watching the clock or cutting a feed short, if the baby's more comfortable and getting a deeper latch, then the feed is likely to go on for longer and the baby's put on more weight. So the two studies we have are from 2020. We have Malenko et al. It was a randomized controlled trial in Italy, and it showed this really good result of so much better outcomes with less soreness and babies feeding so much better. And then the following year in 2021, we had another a meta-analysis from China, and they showed very similar results. Let me see, it was first studied in and published in 2008 by Suzanne Coulson. And she found in her research, she videotaped 54 mother and baby pairs, and she found 20 primitive neonatal reflexes is what she called them. So she defined them into 4 types here, and I have them in the 4 boxes. The ones in pink are the ones that we traditionally associate with breastfeeding. So we'll say babies need to root and suck and swallow, and that's what enables breastfeeding. But she actually found that there were so much more that came into it. You probably won't be able to see me here, but I have a baby, and you'll know when mothers are breastfeeding that babies tend to, if they're sitting upright, they tend to kick their feet out a lot. They might be kicking the person next to them. They might be kicking the lady on the bus, and the feet are going quite a lot. The hands also tend to go, and you'll see arm cycling, leg cycling, hand and foot flexing, all these things, stepping, crawling. They're all listed in her primitive neonatal reflexes. And what she found was in the upright positions that we've been traditionally teaching mothers to breastfeed in, that this can actually hinder breastfeeding, and the baby can struggle and not latch on well and maybe come on and off. And the mother might say, oh, he's fighting me, or he's not interested, he doesn't like it. Whereas if she goes back and relaxes, and she's now laying baby on her torso, gravity pulls baby to her. The feet can kick into the tops of the thighs, or maybe a little bit on the belly, wherever they need to be. The hands now come into place, and baby finds where he or she needs to be. And she said that it was the mother's position that was the most important variable when it came to latching babies on. Instead of, for years, we were concentrating on the latch all the time. So all of these things really come into play when laid back breastfeeding is used. So what does it do? You'll see in these 2 pictures here, the one on the left, I'd say a lot of you will look at it and go, ow, because it looks very painful. If that baby feeds for a lot longer in that position, that mother's going to be sore. And then on the right, she's lying back and she's much more comfortable. Her neck and shoulders aren't hunched up. Baby has a deeper latch, and it works so much better. It enables full frontal contact for the baby. They kind of have a froggy position that they tend to use. They get as much skin to skin as possible, although it doesn't have to be done, without clothing. They get as much contact. They get positional stability, so they're not panicked about gravity pulling them forward. They work really well with gravity. Baby manages an easier milk flow, has the responsibility for latching. They can come off and on as they need. And it avoids complicated latch instructions, pressure on the mother's tender perineum, and then eliminating strain and fatigue and encouraging a much deeper latch. However, it's very different from what midwives and health professionals have been, the way they have been taught to breastfeed, to help mothers breastfeed for years. So on the left is a page from the Royal College of Midwives Guide for midwives teaching mothers to breastfeed. Very much the midwife is the expert. She's holding the baby, she's holding the breast. You'll see in a lot of those images, the mother isn't even holding her baby at all, and she's latching baby on and putting the 2 together. And it does say leaning back flattens the breast, making it much more difficult. There was no research behind that. That's just what was put in. On the right is a leaflet for mothers from 10 years ago, and it actually has a diagram saying this is wrong. So we have to kind of retrain ourselves into how we're approaching helping mothers breastfeed and change the way things have been done. You'll see what we used to have in Ireland to help mothers breastfeed was the bounty book. So you had how to care for your baby. All of these positions were upright. There was no picture at all or mention of laid back breastfeeding. You'll see the footstool being used on the left and leaning forward in the 3rd photo there, and baby very much twisting over and trying to get a latch, but the mother's position itself wasn't that thought about. There was also lots of instructions. So here's your 18 simple steps from the bounty book on how to latch a baby on. Of course, now we know that research shows the best strategy for helping mothers establish breastfeeding is to keep it simple, and that brain changes during pregnancy and birth affect memory and planning. So what you don't need is to give mothers lists of instructions and steps on how to help baby to breastfeed like this. Some of them were very detailed, like imagine attaching a piece of Velcro to your baby's bottom lip and another one attached to the base of your nipple, and now put these pieces together, and it could be very complicated. So it's another good reason to suggest laid back breastfeeding. And this is what has been starting to come on board. You'll see this from 2022, mychild.ie's information booklet. I think most of you will be aware the front of it looks like this, all about finding a comfortable position. Laid back breastfeeding is the position that's suggested, and they're very simple steps. Just hold your baby close, let them tilt their head back, support their body, including their neck, shoulders, and back. And some babies like their feet to be supported too, which brings in the primitive neonatal reflexes about supporting the feet and how important that is. So we're coming on, we're getting there. Midwifery textbooks, you either have Miles or Mays as the big textbook in colleges when you're teaching midwives or teaching students about midwifery. And for the first time ever, one of them now has laid back breastfeeding included in the text. It's been on the go since 1953, and this is the latest edition. Research is traditionally thought of as taking about 17 years. I've heard 16, I've heard 18, but about that to make it from it's published into practice. So if Suzanne Colson's research came out in 2008, we're 15 years on. So we're nearly there, just another little bit to go. Sometimes you feel like it's 2 steps forward and 1 step back. The same year that this was published by the HSE, they also had this as a Facebook post. I think the post itself has been removed, but the photo, you can still search for the photos and still find it on Facebook. And it's nearly a carbon copy of 30 years ago. And, you know, the black and white images of the health professional as the expert latching the baby on for mother and being very hands-on, and the mother in a very upright position. So just to be aware that we need to move a little bit away from that. So now to the study I did. It was a cross-sectional descriptive survey. We had 15 multiple choice questions and one very enlightening open-ended question at the end. We distributed it to 3 maternity units in Ireland, 1 large urban and 2 smaller regional. It was made available online, and so in all we had 9 maternity units in Ireland represented, and this was undertaken in the summer of 2021. We had a total of 253 valid responses, almost equally split between student midwives and midwives. The midwifery roles were represented by not just staff midwives, but clinical midwife managers, CPCs, lactation consultants, all sorts of roles. And the student midwives came from 1st to 4th year, and they also included the higher diploma students who were going on for their postgrad in midwifery. So the first question was, are you aware of laid back breastfeeding as a position to help mothers breastfeed in? And overwhelmingly, they said yes. So that was really good. More than 80% overall have heard of this. If you look at the big green bar at the top, that's lactation consultants. And that made a lot of sense. They have all heard about laid back breastfeeding and use it. But even without that, it's still quite a high result. So we were really glad to see it. The awareness differed a little bit by their roles. So direct entry midwives, whether they'd come through it in the past or you had students who were coming through, they were more aware of laid back breastfeeding than those who had come through the nursing route and then qualified as midwives afterwards. Those midwives who were new graduates, so those with less than 3 years qualification, they were a good bit more aware of it. And that makes sense when you realize that this is something that has been around since about 2010. La Leche League started using it as the position to suggest most frequently about 2010, so shortly after Suzanne Colson's research came out, and it then made its way into the literature and, as you can see now, the textbooks. So it's been around for about that length of time, so it's taken a while to get there. If you qualified a lot longer than that, you may not have heard of it. A little bit of a difference in the year that the students were in, and it was a surprise to us to see that the current crop of higher diploma midwifery students were not as aware. Less than half of them had ever heard of this position at all. So we wanted to make that, highlight that to the universities. But what's happening in practice? So when we asked them what was the most frequent position they tended to use, being aware that there's other variations on it, but just in general, what's the most frequent one you tend to discuss with mothers? 80% of respondents said they used upright positions. So that would be, you can see here on the left, it's either the cradle hold where the breast and they're using and the arm on that side is holding the baby, the cross cradle hold where it's the other one where you're holding the baby with the opposite arm to the breast you're using and your arm is sticking out. Sideline position came in as well, but rugby hold is another upright position that was also used frequently. So they made up 80%. Laid back breastfeeding only came in 6.75%. That's a small number of all the respondents that said that's the one they tend to use most frequently. If you took out students and you took out managers and lactation consultants and you just had staff on the ground, it was 5.4%. So it was quite low. And none of these have really been studied for their effectiveness, except laid back breastfeeding with the studies I mentioned before. However, the cross cradle hold has been shown in an Australian study from 2016 to have mothers end up with 4 times as much nipple trauma as other positions they use. And that was quite a large study with over 650 mother-baby pairs by Robin Thompson. So that one is not a great one to use. If you also, sorry, your pictures are just, yeah. If you also took out those that said they never heard of laid back breastfeeding with those they said they've never ever used it, 40% of respondents have never once used this position at all. And the practice of which position was suggested to mothers varied quite a bit by clinical site, and we found this really interesting. If you gave birth in Unit A, you were 4 times less likely to be shown laid back breastfeeding than if you give birth in Unit B. And this tends to feed in with what we hear from mothers, what a lot of the research shows, that there's a lot of conflicting information out there. We found it even more interesting that other positions were less likely to be shown in different hospitals. So you'll have, if you look at the left, you'll have cradle hold, only 28% recommended or suggested, and almost half of the mothers in Unit B were suggested that hold. So a huge variation depending on where a mother gives birth as to what position she's starting out using when she starts her breastfeeding journey. So who is more likely to suggest laid back breastfeeding? Well, we asked them this and we found that anyone who had breastfed their own babies, who had personal experience of it, they were almost 3 times more likely to use laid back breastfeeding when they were helping mothers. They knew how comfortable it was, they knew how well it worked, and that's something they tended to go with. Anyone who was a lactation consultant or who was working towards a qualification towards lactation consultancy, they were 6.5 times more likely. And those who had participated in training, lectures, conference sessions, even something just like this, even a short hour, or they'd learned about it themselves, when they learned how gravity helps the baby latch on well, they learned how well it worked, the physiology of it, they learned about all the baby's reflexes kicking in, they were 9 times more likely to use laid back breastfeeding with mothers. However, only 15% had any of this training. And it's not fair on midwives. It's not fair to be saying, oh, you should be doing this. And it's so good and it works so well and it's so wonderful. And we don't explain it and we don't give them the skills how to do it. But almost half of those who had heard of the position and had no training said it would be really good and they would like to have it. What it did for them is it really increased their confidence. So when we asked them, how confident do you feel using this position with mothers? 58% without any training said, yeah, I'd be confident to use it. Once they had that training or a simple session on laid back breastfeeding, that jumped up to 95%. And that really helped, as you'll see at the end when we talked about the barriers. Success with laid back breastfeeding, we asked them how effective it was when they did use the position. Almost 95% said it worked. Even if you took out those who had no training at all, 70% said it worked. And it suggests laid back breastfeeding works really well when babies are given this chance. When we asked them about their knowledge, where can it be done? The majority of them felt it should be done on a bed or a sofa. Less said an armchair, and very few thought it could be done in public or in an upright kitchen chair. Again, that's all about knowledge of how it actually works. All of these statements on the right were true. We asked them to select as many as they thought were true. And a lot of them realized it allowed the baby to self-attach and head bob. Quite a lot realized this might reduce neck, back, and shoulder pain for the midwife in supporting a mother with breastfeeding. And they realized gravity helped keep the baby on. Only about 2/3 felt it could be done with mother and baby fully clothed. They thought it was maybe something more for the labor ward or early postnatal times. And only 2/3 realized that it reduced breast problems and sore nipples, which is really the reason to use this. So that needs to be addressed as well. And only about half felt it could be done at a slight incline, and not very many realized it helped with infant weight gain. The last question was, what do you feel are there any barriers for midwives to use this position with mothers, if there are any? And the answers were divided into, we found they emerged, 7 themes emerged, and they were really a lack of something, as you'll see here, and some of this may be no surprise to you. So a lack of education, knowledge, training. It's just not one of the traditional positions taught. My college education was lacking on breastfeeding. Everything I know and feel confident in comes from personal breastfeeding experience or outsourced education. Newly qualified midwife said she had no training on this. No surprise to anybody that works in a hospital, unfortunately, that lack of time and staffing came up as a big reason. It takes time for baby to latch by themselves in this position. We're under pressure. I work on delivery, and you're more hands-on to ensure this has happened. Time on delivery suite, there's very little time to aid in the establishment of breastfeeding, and following birth experiences, there's little time to try more than one position. The attitude is get the baby on the breast and get the woman out of here, which is very sad and frustrating as a midwife. They just felt they didn't have the experience or the confidence, and they wouldn't feel confident suggesting it to mothers. They didn't see it much on the wards. They didn't suggest it. Here's a midwife over 10 years qualified. She says it's not what people have seen on TV. It's not in the media. I'm aware of time, Denise, so I'm going to keep going at a good clip here. Cultural traditional habits came in quite often. Remaining as hands-off as possible is difficult. So those black and white images of how midwives are meant to help mothers breastfeed, they're still in our heads, of putting breast and baby's head together. And in very new research, we have 2 from 2023 that's showing mothers really don't like that. They feel they're manhandled, and babies don't like it either. There are problems latching on when that has been used. This really stood out to me, this quote from a midwife qualified over 10 years. It's easier for mum to attach, but it's harder for midwife to assist baby with latch. And I thought, what's the problem? But I think we're so conditioned to doing something and being hands-on, it's hard. There was some confusion over mums who had C-sections or instrumental births, that they felt they couldn't use laid-back breastfeeding with them, which in fact they can. And this midwife said it's the one she always uses, which makes sense when your core muscles have just been cut open and stitched back together. Laid back breastfeeding means you don't have to sit up and hold your own body together and hold the weight of a baby. You can have the baby on top. And the last bit that came up was that mothers themselves, were reported as being the reasons. And I found this quite sad. Students and midwives said mothers' hesitation, they're anxious, they're unfamiliar with large breasts, flat nipples, mothers are unwilling, the mother's not confident to use this position, her lack of knowledge, they have no experience. But what's our job as a midwife? Our job is to help women gain confidence, to empower them, to understand how certain positions or certain things might work. They're new mothers, they're hesitant and they're anxious in their whole role. And we have to help with that and show them the way, and hope that they leave hospital then having more confidence and feeling empowered in breastfeeding. A few little bits, lack of equipment, ward layout, having chairs, not having chairs, they all come up. And students said that they felt difficulty bringing their knowledge about laid back breastfeeding into the clinical area and confronting their preceptor with a new idea when it wasn't already practiced there. So everything I said, where midwives and students are well aware of it in Ireland, but it's not used because of lack of confidence, time, education, and a continuation to use old traditional upright positions, and some misconceptions as well. If we provide further education to midwives and students on specifically laid back breastfeeding, why it works so well, it encourage greater use of the position and hopefully help women's breastfeeding experiences overall, leading to increased breastfeeding rates in Ireland. And thanks for everybody that helped in this study. And there's a picture of breastfeeding 150 years ago. They were doing laid back breastfeeding. It's nothing new. We just have to reclaim it. Thanks very much.
Yeah, perfect. So thank you for the introduction and for the invite today. So I'm public health nurse here in South Tipperary, and I'm a lactation consultant since 2009. So I have a real special interest in supporting breastfeeding mothers. And I did the pilot post here as lactation consultant in South Tipperary for 4 years until 2022. So again, setting up the breastfeeding groups and meeting mums one-to-one and that. So before, in 2017, I suppose I did the infant mental health masterclass here in South Tipperary. And I suppose it just sparked a fascination really with infant mental health. And I suppose I saw a lot of what they were kind of telling us as to be very associated with breastfeeding and closeness and the attachment and that. So since then, and for the past 5 years, I attend monthly infant mental health professionals network reflective practice groups here in South Tipperary. And these are facilitated by our psychologist who ran the infant mental health group masterclass. In 2019, there's been lots happening here in South Tipperary with infant mental health. They ran a symposium, and the guest speaker was Dr. Kevin Nugent over from America, from the Basildon University. And while he was presenting at the symposium, he also stayed and he did the newborn behavioural observation programme. And that's the programme I undertook then at that stage. It was co-facilitated by 2 occupational therapists who are newborn NBO facilitators. And I suppose I got my certification in that then after doing the course. I'm also a member of the Irish Association of Infant Mental Health, which is associated with the World Association of Infant Mental Health. And they just had their World Association of Infant Mental Health, just held their conference here in Dublin, actually in July. And I suppose I continued. I did an update there in 2022 as well. So I suppose, you know, what is infant mental health? Infant mental health refers to the quality of social and emotional development of children in the first few years. It's a multidisciplinary approach enhancing the aspects of development. And I suppose at this stage, there's inarguable research that positive early relationships experiences matter, and they lay the foundations for positive mental health throughout our lives. So infant mental health keeps the baby in mind. It keeps the baby central to all the interactions. And by keeping the infant mental health approach, it aims to enhance the social competence and the emotional well-being of young children, and hence prevent risk factors and avoid adverse effects on development. So again, keeping the baby central to all interactions. The NBO then, the newborn behavioural observation, was developed as a tool that would support parents by helping them to learn about their newborn baby infants, their behavioural capacities, and really strengthening the relationship between the parent and infant and supporting the family adjustment. It was developed from what was previously known as the NBAS, so the Newborn Assessment Screening Tool. And this was more of an assessment tool, whereas the NBO shifted the focus away from assessment and diagnosis to more observation and relationship building. And I suppose as public health nurses, we do many assessments and screening. So it was lovely then to be able to offer this as an observation tool with parents. So it was created then to sensitise parents to their infants' competencies with a view to help them to understand their infant's behaviour and promote positive interactions. So I suppose, where do parents go when they have questions about their baby? I had a mum say to me the other day during a primary visit, I whispered into Google last night, what do I do for a 10-day-old baby who's doing this? So there's so many places mums find information and look for information online, Instagram, Facebook, grandparents, their friends who give their own experiences, you know, the medical side, ourselves, public health nurses, GPs, paediatricians. So, and I suppose the infant mental health approach would get parents and encourage parents to look at their individual baby. Managing our expectations, I suppose, is a big thing. And Helen Ball at the ALCI conference spoke about it as well. Parental expectations, really, of what it's going to be like with a newborn, you know, versus the reality of it. The societal expectations, the expectations that new mothers should be out and about and up and out of the house soon after birth. And then, of course, as health professionals, we have expectations as well. And, you know, a baby's coming to us sleeping, waking every 2 hours, someone might refer that on, whereas it might be normal. So I suppose we have to manage all our expectations. So infant mental health keeps the baby central to all our interactions, and the foundations of good mental health comes in the first early years. So Kevin Nugent would suggest while the first 3 years are important, the first 3 months are essential. And I suppose it's about promotion, prevention and intervention. And I suppose as a public health nurse and lactation support, I'm working really as a promotion and preventative side of things. The group I am in, the network group, they'd be coming from all different backgrounds. There's social workers, community mothers, community support workers that work in Cools there. So I suppose coming from different perspectives as well. So the infant mental health approach enables parents to be curious about their baby's minds. It tells us babies are trustworthy. When they cry, they're communicating and they need something. And advising parents and telling parents what to do is very much contrary to the infant mental health approach. We enable parents to take ownership, and they're the experts in their baby. We walk beside the parents, we guide them, we listen to them. And I suppose on a broader scale, being in, I suppose, keeping infant mental health for the last couple of years, to be aware of, you know, what the baby's born into. There's a lovely article I've referenced, it Ghosts in the Nursery. And I suppose as parents, what we bring to the nursery and what a new baby can unearth if there is negative, if that parent had a negative experience in their childhood or a negative relationship in their childhood. And there's also the angels in the nursery, that the good experiences in life that we bring when we are parenting our own children and babies. So the ENBO then is carried out in partnership with the parents. So it's not me doing it, I do it in partnership with the parents, and it's from babies from birth to 3 months. And even though this time it's a really short period in life compared to the rest of life, it does, as we know as lactation consultants, consist of a series of pivotal, life-changing, both physiological and psychological transitions in the newborn, and indeed for the parent and the emergent infant-parent relationship. So the ENBO offers parents information on their individual baby, completely unique to their baby, their communication strategies, their overall development. And this in turn then, you know, strengthens the relationship between the infant and the parent. So rather than, you know, getting advice from Google or searching, why is my baby doing that? I'm getting the mums to look at their baby and finding the answers in their baby. So it supports parental functioning. The ENBO can be used to support parents at a time when the very basis of parental function are being established, and it sensitizes parents to their infant's capabilities and individuality. It's done very much in partnership with the parents, so it enables the parents to identify what the baby's likes and dislikes. So it's a lovely, lovely way to invite the parent to work with me. And it's a way for the parent to discover the uniqueness of their baby, and provides opportunities for the parents to suggest what the baby's telling us. And it strengthens this relationship between then parents and infants. It's not an assessment, but the parents do get a feedback form, and there's nothing new on this feedback form because they've very much done the observation with us. And again, so that enables like this lovely positive relationship between the clinician and the family. And as I said, some of my colleagues will be working with babies and mothers who have maybe been through a trauma, and I suppose you know, some mothers or parents could be questioning, do you know what I mean, professionals and that. So the ENBO really, I suppose, supports that positive relationship between clinician and family. So undertaking the ENBO then, it consists of 18 newer behavioural observations that describe the newborn capacities. So from birth to 3 months of age, as I said, it looks at the capacity to habituate to external light and sound, so the sleep protection, the quality of motor tone activity level, self-regulation, the consolability and the suitability. We look at the response to stresses, physiological stability, the visual and auditory and social interactive capacities of the baby. So they coined this lovely word called amour, you know, amour, the French word for love. So again, to describe what we look at when we're doing an ENBO. So it's the autonomic stability, we're looking at colours, tremors, startles, motor stability, state organisation and responsiveness to social stimuli. So when we did the course, we were all received a copy of the book, The Understanding Newborn Behaviour, which is a lovely book from an infant mental health point of view. And also we were given a little bag with our little red tracking ball, which we use for the babies to track, and the little sound one as well that we use as well. So that was all provided to us at the course, and a little pen torch as well to the light stimuli. So those are the 18. I wasn't able to put up the actual assessment that we use, but those are the 18 little states and observations we look at. And sometimes, as I said, you know, it depends on the baby. We always keep the baby central to everything. So if the baby isn't asleep during our consultation, for instance, we wouldn't be able to do the first ones, the habituation to light and sound. The baby needs to be asleep for those. And sometimes it could be just 4 or 5 I'll get done at an appointment, but that might be just enough information, and that might be just enough to get the mother or the parent thinking about where their baby's at and what their baby's telling them. So you wouldn't necessarily have to do the whole 18 with, or it might be another subsequent appointment. So where have I used the NBO? I suppose when I was doing as a lactation consultant, we get brand referrals, GPs, public health nurses, self-referrals, and sometimes they are breastfeeding issues, and I'll do a lactation assessment and support the mother. But I suppose I'm using an infant mental health approach where I kind of, you know, it's not instructive, and sometimes as well we get issues like sleep issues. So because the baby's breastfeeding, it's maybe seen as a breastfeeding issue. So again, back to you know, our perceptions and what is normal in that. Babies being described as unsettled, a little breastfeeding baby described as unsettled and fussy, and the baby who's, you know, been termed maybe a colicky baby or has reflux. I've used it with young mums who just kind of lacking that little bit of confidence in themselves, and certainly I've used it with mums who are just struggling with the early day and week adjustments of their new baby, and I suppose the overwhelmment of what breastfeeding brings and the reality of breastfeeding. I've used it in cases like that as well. And as I said, sometimes babies do come in, you know, if the mother's describing them as, you know, unsettled and fussy, maybe colicky. I suppose it's, you know, doing a lactation assessment and seeing how the breastfeeding is going is one thing, but telling her no, everything's fine and going home, she still feels that there's an issue, I suppose. You know, that's a worry for her. Whereas I found doing an NBO was kind of reassuring in that she was getting answers. And do you know what? I really think my baby likes this, or I think I'll try this. And that was instilling a confidence in the mothers going home, you know, a confidence in themselves as parents and mothers. So that's just a little example then of an NBO I did with a mother, this mum and baby. They had a difficult start. The birth was difficult. It was quite stressful, instrumental delivery. And I suppose in the hospital, the babies had some top-ups given in the early days. And so was a little bit slow to weight gain. And hence I got an original referral for lactation support. For mum was sore and there was top-ups and slow to weight gain. And between myself and public health nurse, this mum and baby were back exclusively breastfeeding by 4 to 5 weeks, and you know, successfully breastfeeding, exclusive breastfeeding where she had wanted to be. So mum contacted me again. Mums would always be left my number around 9 weeks, and just phoned and just described her baby as, you know, really fussy, not sleeping, refusing a bottle, and she thought the baby, that someone had told her the baby might have reflux because the baby won't take a bottle. So she was quite tearful on the phone, and we chatted. And I suppose I had known her, I had done the lactation support with her in the early weeks, and we chatted, and I invited her to come in, and we kind of went through things. She'd offered a bottle because she was told that if she didn't give a bottle, the baby would never take a bottle. So, and then when I broke down, like, you know, there was no reason really why the baby had to get a bottle, and she was kind of just, you know, doing it because someone else told her to do it. So, and we just went through, you know, what the baby's routine was, how the breastfeeding was going. And we started the NBO together. A lot of the mums would know I often speak about the infant mental health approach at breastfeeding support groups. So they often hear me mention it. And so I suppose we got great interaction. One of the things we use is the red ball for tracking, to get the babies to track the red ball. And we also use the mum's face. And I suppose this baby was really intently gazing at the face. She kind of really overwhelmed her, really. The baby just loved being upright and looking at the mum's face. And she just started to describe him as loving the FaceTime. And I suppose you pick up on these, you pick up what the mum is picking up. And as well, the baby was really active, motor skills, kind of in the tummy time, there was huge movements, and mum started to say, I was kind of putting her down at a time, and maybe she needs more of this. And I think you're right. I totally think you're right. I think that, you've hit the nail on the head. I think your baby just loves being up with you, loves more tummy time with you, constant FaceTime. And I just asked her, had she a sling? And she said she had, and she hadn't used it, and she hadn't thought about it for use in the house. So I suppose she took a lot from the NBO. We only did a few little bits. I wouldn't have done all 18. The baby was quite awake. But I suppose, when you make that kind of follow-up phone call and she's kind of saying things like, I'm just listening to her now. I'm just doing I'm just going with her. So I suppose instilling that confidence in the mum.
5
And that
minutes.
was Thank you. Thanks, Denise. So again, that's another mum that contacted me, I think herself, about baby was 5 weeks, breastfeeding, went well from the early days. I didn't see her in the early weeks of breastfeeding support. She was an instrumental to deliver her first baby, but she came to me and contacted me about 5 weeks, sort of describing a very frequent feeder and not settling, and kind of thinking maybe the baby had wind or reflux. So again, came to me from a lactation, for lactation support. So when she came in for the assessment, she was quite tearful, she was exhausted, and I suppose she cried and I listened. And I suppose, again, from a lactation point of view, breastfeeding was going really well, but she was describing these very frequent feeds in this unsettled baby. And she, again, got lots of suggestions and looked around. So we did a little NBO because the baby was asleep. And when he came in, he was in his little car seat initially. And the baby was very, very stimulated to light and sound. And the mum totally said absolutely, no matter what, a pin drop and this baby was awake, and sort of very hard to settle. So I suppose it kind of told the mum, yes, gosh, this is right, this is, and I said, yeah, absolutely, your baby isn't, you're right, your baby isn't in a deep sleep, or is hard to get into a deep sleep. So the mum, the baby woke and did a feed, and we continued on with the ENVO. And I suppose we found a lot little different things together. The soothability took a little bit of time, and the baby was a little bit unpredictable in state transitions with some abrupt startles and things. And during the face tracking and the red ball tracking, it had some resistance to one side, but the mum had already told me about forceps birth, and she had been referred to physio. And at that point, she was also contacted an osteopath herself. So the mum had felt herself there was an issue, and I suppose doing the ENVO did kind of confirm those suspicions she had. And I, confirmed that, yeah, do you know what, she's right. She's going down for an osteo review and physio referral, and that there was something with this baby that was kind of waking him a little bit more often. It wasn't a breastfeeding problem. It really, the baby was feeding a lot, it just wasn't very settled. And I suppose, again, the mum leaves the office with that confidence in herself, going, I'm right, and everything's right in the world. And of course, the interactions and the relationship is that little bit closer, rather than going home with this, very upset baby, and consistently waking very often. And she had answers in herself. So I suppose the infant mental health approach, I've just been using it because I suppose it's coincidental that I did the ENVO during, when I was seeing mums and babies for lactation. And what it has changed my practice in slow down is to, big time taught me to slow down and listen, because the parents are the experts, and parents will often come in and say, oh, you're doing great, oh, you're the expert. And I slow them down, saying, absolutely not, you're the expert, you're with this baby every day, we have lots of information and stuff, but you are the expert in your baby. And sometimes there does not need to be an answer, and there isn't any answers, as we know that in lactation and in child development, sometimes there isn't an answer. Each baby is unique, and their needs are very individual, and as I said, sometimes there is no answer, it's time. The parent is the expert for their baby, and enabling parental and maternal confidence is key. I suppose acknowledging, and it's acknowledging an awareness of the ghosts in the nursery. And I suppose, even before a baby's born, you're thinking about the rates of anxiety and depression, postnatal depression, antenatal depression, and what is it like for the baby before they're even born, if the mom has depression, if dad hasn't work and things like that. So it just gives me I'm always aware of things, and what the baby's coming into. Keeping the baby central to all interactions. Dads are transitioning to parenthood too. I suppose the infant mental health approach has really shown me, you know, I suppose the importance of dads. Dads would be cited in the literature as, you know, one of the biggest supporters, the dad and the maternal mother, for a breastfeeding mammy. And I suppose, you know, as public health nurses and as public health nurse, I go into houses, I, you know, do the primary visit, I check the mom, see how she's doing physically, emotionally, psychologically. I check the baby from head to toe, we do the feeding. But there isn't a question, or there isn't somewhere for me to document that dad's doing okay. And Helen Ball, again, at the ALCI conference last week, reported 10% of dads suffer with, you know, paternal postnatal depression. And I suppose the reporting, you know, I suppose those figures could be skewed because we don't know about the reporting. So again, that's huge. And I suppose dads are just, you know, someone in the corner going, oh, sure, aren't you grand? You didn't have to do anything. But, you know, when a baby's born, a mother's born, and a dad is born too. And sometimes, you know, we need to ask them how they're doing too. So it's given me a deeper understanding of the psychology of breastfeeding. And I suppose time is perhaps our biggest referral, that mums and babies just need time with us, and an appreciation that someone's with them. So I'm just sharing some links there, the last slide there, and I suppose a referral pathway for us in South Tipperary. We can refer into the child psychology referral, and we can also do an infant mental health referral to our psychologists as well if we need. Those are two links that are on My Child for their little videos on responding to your baby's cues to share with parents. Our own psychologist Audrey was involved in one of them, and the other one is from the Brazelton University, which is a lovely 7-minute video with beautiful, quite lovely music behind it. There's also 4 modules on HSE land that can be taken as well for an understanding of infant mental health. So there's some references, and thank you.
It is National Breastfeeding Week. It is Breastfeeding Week every week for those of you who are supporting mums and babies all around the country. I suppose like there's efforts all around the country to highlight what we're doing. And just this week alone, I suppose we're breastfeeding friendly launched in 3 counties, Waterford, Leitrim and Cork. We have a number of in-person education events, and certainly I've seen lots of photographs of our HSE colleagues and our volunteer colleagues getting together all around the country. There's promotional work on the legislative changes, and that's been incorporated into We're Breastfeeding Friendly. Really important sharing of auditing work around the use of the boat tool, and just in general, coffee mornings, chats, kind of press releases, newsletters, infant feeding committees, sharing updates, and all that's really important, just kind of getting out about what support is available locally. And I think this year in particular, because we have a lot more people in posts in community areas, we're getting a lot more local traction, I think, on different events. So that is a really that's a really positive you know, mark this week. And I have one photograph to the left hand side to not underestimate the I suppose the scale of the challenge. Those of us who are on Facebook or social media are being bombarded with industry advertisements as well this week. So even more important, I suppose, to make sure that we are getting out with our consistent you know, messaging, and even just on foot of Marie's presentation there, and even, you know, with Margaret around what's normal in the early days and signposting to HSE supports, and not you know, kind of letting mothers know what's available, so that they're not going on to care lines that are not related to evidence-based practice. So just a little bit about, I suppose, on rates in the last year. Obviously rates are going up modestly, but they are going in the right direction. So the data for last year that we currently have is on the public health nursing visits. So we're just tipped over 61% of mothers that are breastfeeding, they're exclusive and non-exclusively breastfeeding at the first PHN visit. Our exclusive rates are kind of staying around the same, or a little bit under the 40%. Any breastfeeding at 3 months is hitting about the 43% mark, and again the exclusive breastfeeding rates are staying relatively stagnant at 3 months. Huge variations around the country, as I spoke about this before. You'll have heard me saying we have rates between 47% and about 75%. So breastfeeding looks very different in different parts of the community, you know, in different parts of the country. We have IMIS data from the hospitals. That's a waiting publication that's kind of showing kind of similar trends the last couple of years. But more interestingly, we're looking at about 5 hospitals have reported breastfeeding discharge rates which are higher than the initiation rates. So I suppose people are trying breastfeeding in hospital, maybe getting a little bit more support that may not be possible at the first feed, but are trying it. So that's been borne out in the smaller hospitals' data, more so than the bigger hospitals. But it's interesting. For the first time, I've seen 5 hospitals with data on that regard. There was about 2 hospitals the year previously with that. I know certainly the introduction of more widely available practices around antenatal colostrum harvesting, maybe enabling more mothers to get colostrum if that's permitted during pregnancy, the latter stage of pregnancy. So I just wanted, I suppose, just to kind of show up a little bit about the breakdown, a little bit behind the rates. And obviously this is kind of useful for those in planning lactation support services to understand, I suppose, a bit about the breakdown that is produced by the HPOs. We know the NPRS reports are produced annually. The latest available report is from 2020, and it really looks at certain measures within maternity services and is tracking those every year. So we've always had breastfeeding recorded at the point of discharge, which is different to the IMIS reports. So their IMIS reports are looking at breastfeeding initiation and tracking what exclusive and non-exclusive breastfeeding rates are looking like since birth, but the NPRS data is recording at the point of discharge. So I suppose, again, just kind of looking at it, about the variations, as we know, exclusive breastfeeding is on the way down, and certainly over the last decade we have seen about a 3% decrease in percentage points in that way. The numbers of Irish mothers kind of has remained stable, or kind of just up 1% over the last decade. But more interestingly, the proportion of mothers from countries outside of Ireland all show, say, significant decreases in exclusive breastfeeding over the same decade. And most significantly, Asian mothers, down 26% of exclusive breastfeeding. Now, whether we can draw any kind of comparisons with other kind of explosions of commercial milks being sold in those countries, I don't know, but it's just an interesting finding from our point of view here. So we know breastfeeding is typically more common in the higher professional socioeconomic groups at 61%, and least common with unemployed mothers at 27%. Breastfeeding increases, we can keep it on the same one, Justin, thanks. Breastfeeding increases with mother's age up to the 35 to 39 group, where it kind of declines after that, and indeed mothers within the 35 to 39 age group have the highest rates of breastfeeding, just hitting about 50.4%. Mothers born in Ireland have the lowest rates of exclusive breastfeeding, and mothers from EU countries report a high proportion of exclusive breastfeeding at 65%. There's certain areas which have higher rates of exclusive breastfeeding around the country. So looking at Cork, Kilkenny and Kerry. We know C-section rates are on the rise, and the NPRS reporting data there by 35%, which is up from 28% in 2011. And I know indeed hospitals even say some of their C-section rates are even higher, higher than that. And then looking at length of stay, from women having singleton births, by about 59% have a postnatal stay of less than 2 days or less, or 38% of postnatal stay of 3 to 5 days. Interesting, that doesn't go into any breakdown of any of the supportive care pathway. As we know, breastfeeding rates can vary. And we have very good breastfeeding rates where mothers are within midwifery-led care pathways, in particular domino, early discharge home and home birth pathways. So that data isn't available to us in that regard. Go on to the next slide, Justin. So the National Breastfeeding Action Plan, so the term of the plan was extended to this year, to the end of this year. We do have a governance group under the National Healthy Childhood Programme for that. So it's really interesting for us. We're beginning to reflect, I suppose, on the plan, and we're kind of at stage of thinking about what our review of that plan is going to look like. Interestingly, up to about 3 years ago, there was no additional funding except for the nurture programme, and since then, obviously, we've had investment of lactation posts. As of this year, just my own review of the actions. 14 actions have been completed and are ongoing. They're not completed and stopped. There is a significant body of work to keep those ongoing. 14 are in progress, and 2 of the actions haven't commenced. The 2% increase of rates of it hasn't been met. We have infant feeding committees in majority of our CHO areas, and they have been instrumental, I suppose, in driving breastfeeding supports. And we have committees within maternity services for baby friendly. So from my own perspective, I suppose what's needed after the end of this year, we have data available up to 3 months, up to breastfeeding rates up to 3 months. It'd be really helpful to see more up-to-date information on attitudes towards infant feeding and feeding behaviours beyond 3 months. In Ireland, the last data we have is from Growing Up in Ireland survey, the Growing Up in Ireland survey. We anecdotally know that more mothers are breastfeeding for longer, but it'd be really helpful to have more kind of an up-to-date picture on that. We obviously have to progress outstanding actions, looking at to review the action plan and looking at the findings of that to inform future iterations of the plan. We would like to target supports for mothers less likely to breastfeed, and certainly look at restricting advertising of commercial milks within healthcare settings. We have legislation in now on breastfeeding breaks as well, so certainly encouraging and supporting more mothers to avail of breastfeeding breaks in the workplace as well would be a priority for us. Yeah, the next slide, Justin, thanks. So just to give an update on investment and lactation supports, between 2020 and 2021, between the National Maternity Strategy and the Minister, there have been, I suppose, significant increases in the number of posts allocated. And that was to ensure more nationwide coverage within hospital services, proportional to birth rates, and also within the 32 public health nursing services area. So this is the live figure, and it's always going to be constantly updated. But as of in the last month or so, we do have 57 of the WTs in place, and just 2.5 of those posts are in recruitment. And they are in recruitment, and some of these campaigns just had to be redone, so they're at the later stages, of that. So we should have all posts in place, by the end of the year, and that's been, I suppose, quite a piece of work to do within maternity and public health nursing services in terms of kind of advertising, recruitment, and kind of reallocating these roles, then. So thank you to everyone involved in that. So we have about 35 staff working in maternity services, more to come, and 21.6 WTs within community services. We know we have about 200 staff working in various roles across the health services, and again, more to come. I am hearing all the time of public health nurses or midwives undertaking the course. I mean, recently, this morning met a lady at a breastfeeding group who's a neonatal nurse and undertaking the course while she's on maternity leave. So there's a huge commitment to people wanting to do further training in the area of lactation, with the view of kind of supporting in their own workplaces or for future roles. So the roles of our infant feeding lactation midwives are primarily to, I suppose, like that, increase access to lactation support available. So that looks very different in different areas, and certainly in the maternity services, there's a lot of emphasis on supporting mothers antenatally and seeing mothers who've had previous breastfeeding issues or have medical conditions, and investing, I suppose, supports in kind of supporting antenatal colostrum harvesting with the antenatal services. So there's a lot of kind of emphasis on that space, and then obviously to the postnatal care as well. In the community services, the roles are really looking at re-establishing in some cases, or certainly in a lot of cases, setting up brand new groups, PHN-led groups in the community, and there's also an emphasis on making sure that there's virtual options available, because that hybrid model is what parents are telling us that they want. And then depending on capacity, certainly they are advisor to public health nurses, their own colleagues around kind of care moms receive, and they will provide a one-to-one service as well. So every public health nursing service has at least a 0.5 WT within their services, and even with the allocation that they would have received, a couple of directors of public health nursing have actually increased that allocation to a full-time post, which has been really welcome. Really welcome. And as many of us know, that these posts are just the beginning, and it's like seed funding to kind of set up good structures within primary care. So we would hopefully to see the number of these posts increase as the years even go on. Okay, the next slide, Justin. So the next thing I just wanted to give a brief update is on the baby friendly initiative. So Claire Kennedy, my colleague, is the lead for this quality improvement programme within the National Women and Infants Health Programme. So the National Women and Infants Health Programme are providing governance for the baby friendly initiative, and standards were published last year. And This year then, so a significant piece of work was done is around the developing self-assessment tools, and these were launched to all the 19 maternity units back in April. And what's going to happen, that services will self-assess them against themselves, against the standards, and that looks at the maternity services in general in terms of the environment, management practices, governance, as well as interviewing staff and interviewing mums about their experience. So all 19 units have completed the self-assessment process for this year, and the results and the action plans indeed are being analysed currently by the National Women Infant Health Programme, by Claire. Also, so significantly, kind of positively in the last year or so, we've had the establishment of an infant feeding specialist forum within maternity services and within the community services. I'll talk about the maternity one here, first, and that's really to support our infant feeding specialists as they implement, as they begin to plan, and implement the standards, and really important information sharing and piece. And we've held kind of workshops and kind of have priority actions which we've been working through this year. And the group has met bi-monthly in person at various sites around the country, and there's also been virtual options as well for people to attend. So all of the 19 services have attended nearly all the meetings. It's been a very highly valued forum for our infant feeding colleagues within maternity services, particularly over the last year. And we've also established a baby-friendly oversight group to oversee implementation of the national standards, and very, I suppose, broad representation of key stakeholders within the HSE, and certainly within communities where mothers are less likely to breastfeed. So that's been a very positive forum to date, which has been established to oversee the implementation of the standards. As that it might be seen there, the slide, but there's also just a web link towards the Baby Friendly Initiative webpage on the National Women Infant Health Programme, and I suppose progress updates will be put up there. So the next slide I just wanted to kind of touch base on is a National Infant Feeding Education Programme, and maybe many of you here may have been involved in the kind of the train the trainer kind of aspect of this to date. So over the last number of years, we have been looking at the standardising an education programme for frontline staff, primarily initially targeting midwives and public health nurses, and with real emphasis on the basic skills for midwives and public health and for public health nurses that they need. People will be familiar with the 20 hours education. All of the international evidence is kind of emphasising is around the skills that people need and education they need, and hours of training, I suppose, has been removed. This programme has been developed alongside midwives, public health nurses, IBCLCs, educational technologists, and UCC in terms of advisors around kind of best practice around education. The face-to-face element is heavily kind of really concentrated on 3 core skills, promoting safe skin-to-skin contact throughout the postnatal period. And it's really interesting to hear Margaret's presentation there around laid-back feeding and around teaching mothers to hold their baby, and certainly laid-back feeding from what we have, been our experience in terms of delivering the pilot programme, and even with the infant feeding forums, our lactation consultants who are working with the maternity and public health nursing services primarily are only teaching laid-back feeding, to mothers and to their colleagues as the go-to comfortable position for for mothers, and that's borne out in the education in terms of how the skills-based training will be rolled out as well. And then really focusing on teaching mothers how to hand express their breast milk, which is a very useful and valuable skills for mothers to learn. So we have resources behind the project for the National Healthy Childhood Programme in terms of materials. We're working with the CNMEs in terms of rolling out face-to-face training, and there is also for IBCLCs 13 IBCLC credits as well for that programme.
Just a few more minutes, Laura, sorry.
Okay, no worries. So just to highlight breastfeeding supports that are available, it's National Breastfeeding Week, so it's just to highlight the range of supports that are available and consistency of messaging across our across our various platforms. We have 198 breastfeeding groups up and running as of last week. I think our press release said 180, but as of this week there's 198. So there's a big drive to get more breastfeeding groups on the website before National Breastfeeding Week, so that's really important. So yeah, you can read that, but just to be a kind of, I suppose, aware that there's lots of resources behind all the different various content, and they are all regularly updated, and their messaging across all of our platforms is all is all updated also, with next iterations of that. So the next slide is just, I suppose, just to touch on the code, given the week that's in it. So just to kind of remind people that if there are breaches with the legislation, people can kind of make a complaint with the Food Safety Authority. I did myself only last week, driving down from Dublin, and I saw a number 1 formula at the point of sale of the till. Number 2 formula technically is allowed within the legislation, but certainly the number 1 formula isn't. So just to remind people that facility is there, where the FSCI will get an environmental health officer to review that. Baby Feeding Law Group Ireland also would like us to report breaches of legislation so that they can compile a repository of breaches on the code. And again, just to remind us, remind ourselves about the HSE publications we have around how we can work within the code better within our own professional resources, kind of making sure the information we're giving is in line with evidence and not to be supporting industry funded events and that. The next slide, just wanted to touch base on a kind of research paper I came across. The Lancet series first. So Lancet series, I suppose, is seminal work on breastfeeding, seminal work on the importance of breastfeeding, and really because thinking about Margaret's presentation as well, even about like normal newborn patterns don't align with with adult sleep patterns, and it's the evidence would show that it's very normal for babies to have crying and fussiness episodes, and then reframing normal as a marketing opportunity. So the scale of, I suppose, in just terms of the conflicts with public health messaging, and commercial industry is ever present. So even more important that we have good supports available for parents, and to kind of and to signpost them to the available supports that are available in their area, so that they are going to us for support and not going to industry for advice and support. The last piece I just wanted to touch base on is giving the code, and the next slide just is on the preparation of formula milks. So just we know from the evidence and kind of a couple of research papers that the use of these preparation machines are really, really popular with parents. Clearly there's kind of great consumer protections needed, but they are there. So just to re-emphasize that these formula preparation machines are not recommended by the FSCI and the HSE, and we do have advice on this regard on the HSE on the HSE's website. There isn't enough evidence on the safety, and basically that the water in these machines may not be at the required temperature of that to kill any potential bacteria that may be in infant formula. So that's just a whistle-stop tour. So thank you.
Everybody for listening and for attending today, and I'm delighted to present today on behalf of the team of our local Well Baby Breastfeeding Clinic in Galway City. I'd like to thank the organisers for inviting me to present. So, sorry now. Okay, so there's the team there. So we've Director of Public Health Nursing, Public Health Nurse, Dr. Ethel Ryan, Dr. Sinead Gavin, that's myself. We have Maggie Coyne, Public Health Nurse, and she's just waiting for her IBCLC exams. We have our admin there, Mary Boyle, and Frances Burke, our Community Lactation Consultant. And also there's a team of public health nurses that work in the clinic as well. So the Well Baby Breastfeeding Clinic was established in December 2021. It is a collaborative service between the Departments of Public Health, Nursing and Neonatology from University Hospital Galway. The governance is with the Director of Public Health Nurse, Helen Martin, and Dr. Ethel Ryan, who's a consultant neonatologist. Dr. Sinead Gavin then is a GP, a lactation consultant and a tongue-tie practitioner. So she's the clinical lead. And then I would have governance over the clinic from a child health perspective. And then the public health nursing team, who are so important, they help Dr. Gavin in the clinic, and she liaises very closely then with our community lactation consultant, Frances Burke. So in 2020, Ethel Ryan and Sinead Gavin began working on the formation of the Well Baby Breastfeeding Clinic through a quality and action project within the Saleha group. This was in response to an identified need and babies presenting to the emergency department with minor feeding issues. There was no alternative pathways available for these women and babies, or breastfeeding rates were low. The 3-month exclusive breastfeeding rate for Galway at that time was 24%, and combined feeding was 35%. So that's the 2022 data. So Dr. Ryan approached the Director of Public Health Nursing for Galway, and a collaborative approach to delivering a well baby breastfeeding clinic in the community was a result of that. So diagnosing the issues, so why weren't women breastfeeding? So the data showed that some of them weren't breastfeeding for personal reasons, so they'd low maternal confidence, privacy and regarding to breastfeeding in public. They'd lack of family support or partner support. The hospital staff, the lactation consultant support was not available on a daily basis, inadequate time or privacy, and the variances in breastfeeding knowledge between the midwives. In the clinic, then clinical reasons were premature sick baby, sick mum, low milk supply, or poor early recognition of problems. And then there was financial, the cost of either buying or renting breast pumps, early return to work, state benefits, then the family, no support, other children to look after, discouraged by their own mother, and then educational, societal support, unaware of benefits, or inadequate staff training. So the clinic then was the first combined community and acute care breastfeeding clinic in Galway. As I said, it's a joint initiative, and it aligns with Launch Care. It offers timely support to mothers and breastfeeding issues. A variety of common feeding issues are assessed and treated in the clinic, and an infant oral assessment plus or minus a frenotomy is offered if indicated. So that's a tongue tie release. So you see pictures here of the baby before and after tongue tie release. And also it's a free service. So it's based on best practice quality care and the HC core values of care, compassion, trust and learning. And it's a prime example of Launch Care initiative where acute and community services merge to create a service that is patient-centred and by making every contact count. And this is in line with the enhanced community care model. So the Quality in Action project used qualitative research methodologies where mothers were asked to share their experiences both in the hospital and the community up to 8 weeks postnatally. Common themes emerged where the mothers were unaware of supports available, they felt rushed or lacked privacy, the infant oral assessment was not routinely performed, and I know it wasn't performed when I was a midwife many years ago, and many had to seek help privately, and we all know the early support is critical to the breastfeeding relationship. So post-consultation with relevant stakeholders, the collaboration took place and the clinic started. The aim of the clinic is to offer timely support to mothers with breastfeeding issues in the early days and to assess and treat the feeding problems. And of course, it's free of charge, which is so important. The Well Baby Breastfeeding Clinic was established in response to an identified need from mothers as per the HICWA National Maternity Experience Survey 2020 and in line with Enhanced Community Care and Launch Care. Collaboration is the key to success. So here's a mum now and she's at home and she's breastfeeding and she's run into problems and she had no idea where to turn to or what to do. She desperately wanted to breastfeed. Her nipples were cut and bleeding. Is this normal? And they mentioned a slight tongue tie. Do I need to do something about that? So these were all the issues the women were having at that time, the study. And don't forget now, this is during COVID times. So first of all, you have to understand the system and identifying stakeholders within the hospital and community sectors for this project to get up and running. So you have the mother and baby at the centre, you have your lactation support, your midwifery team, your GP, your public health nurses, ear, nose and throat, and neonatal team. So yeah, I suppose before this clinic was up and running, there was only private tongue-tied practitioners in Galway and there was no public service. Well, there was through the ENT, but mothers and babies had to maybe wait a few weeks before that. And at that stage, then the breastfeeding, they'd given up on it, unfortunately. So the aim of the breastfeeding clinic was to improve breastfeeding rates, to reduce the burden on acute hospital care and enhancing community care. So it's keeping them mothers and babies with feeding issues out of the A&E, out of paediatrics. These were issues that could be dealt with in the community. And I'm delighted to say since last November, we also got a community lactation consultant in Galway, Frances Burke, and she works full time. And she works, we tic-tac between the clinic and her role as well. So it's just been brilliant. Now, it's accessible to all mothers, and it's making breastfeeding a positive experience, and it's empowering women. Just a bit about breastfeeding research in Ireland. Many of you will be aware of the Baha study that came out last year. It's breastfeeding support in Ireland, which surveyed over 5,000 mothers on their experiencing of establishing breastfeeding. And they identified the public health nurse as the healthcare professional whom they'd most seek the most support, and that's 62% of the mothers. The Baha report also found that 57% of mothers sought private breastfeeding support at an average cost of €309. So that's a lot of money, especially in the current times. So breastfeeding is promoted as the best way to feed a newborn infant due to its many benefits in both the long and short term for both mother and baby. However, breastfeeding can be difficult to establish in the early days, and the mother needs a lot of support, and it can be difficult to access support in a timely manner, which is critical to the breastfeeding continuation and duration. So yeah, during COVID-19, mothers weren't seeing their GPs face-to-face. They were seeing their public health nurses, but there was definitely less face-to-face time and supports for mothers. So the only place they had to go then, if they were running into problems, would be the A&E department. So I'm so glad that we've rectified that now in the community. So mothers who are experiencing breastfeeding issues in the community now and difficulties, and if the public health nursing intervention has been unsuccessful, the public health nurse will then refer the baby to the Well Baby Breastfeeding Clinic. The babies are invited to attend the clinic for a review within a week, and feeding of the infant will be assessed by the doctor, IBCLC, and the public health nurse. Now, we've increased our clinic, so they're seen within a couple of days now, which is wonderful. So communication. So improved communication between the hospital and community care. The discharges on an Evolve electric service. So when we're doing our auditing now, and babies have been seen in the Well Baby Breastfeeding Clinic, Dr. Sinead can go on the Evolve system and see if those babies have attended A&E or paediatrics since, which is brilliant for data collection. We have excellent administrative staff, which is testament to how well the clinic is doing. They understand the importance of the service, and cancellation appointments are promptly filled. And since January 2023, we're offering 2 clinics per week, with a third commencing this month, October 2023. And the clinic staff liaise and work closely with community-based IBCLC, public health nurses, and hospital-based IBCLCs who refer to the clinic also. And so it's primarily public health nurses who are referring. Then you could get the hospital lactation consultants referring to our clinic, and GPs as well. So the clinic is a multidisciplinary approach, as I said. So you have your tongue-tie practitioner and a public health nurse in each clinic. It's a successful collaboration. It's for follow-up and continuity of care between the services. It is a community-based service with access to acute care. There's instant communication between the teams. The discharge from the clinic is completed on Evolve and distributed through health mail to the GP and public health nurse on the same day. So if there's a follow-up for a wait or a review, everything's done quite speedily. There's a multitude of feeding issues that can be addressed in the clinic. So you've got your infant oral assessment and frenotomy performed if indicated. And some babies have tongue ties, but they have no restriction with them. So those babies do not need their tongue tie divided. So it's important for, you're meeting an expert and she's talking through everything with the parents, and she's a tongue tie book that she's made, and she shows them pictures of what needs to be divided and what is and what isn't tongue tie. So it's a good visual cue for the parents as well. And sometimes it's just reassurance for the parents. They might think their baby is tongue tied, but that's not maybe the issue with the breastfeeding. So people are seen quite quickly. and the number of infants attending the emergency department and neonatology clinics has significantly reduced, and that has been confirmed by the paediatrician, Dr. Ethel Ryan. So in terms of measurable outcomes, there's 750 babies seen to date between January of 2022 and October of this year. In the first year of service, which was 1 clinic per week, there was 270 babies seen, which was just over 10% of the total births of all babies born in Galway University Hospital. This shows an excellent throughput of mothers and babies and bodes very well for the future in terms of benefit to the service user. So we audited 40 files at random, and what we found was 27.5% of the babies had a poor latch, 47.5% had nipple issues, 15% had poor weight gain, and 40% of babies seen had tongue tie issues. So what our audit also showed that our exclusive breastfeeding rates have increased from 24% at 3 months to 57% for the Well Baby Breastfeeding Clinic attendees, which is a massive jump. It's more than double. So the user experience rated service as valuable, vital and unique, with 97.5% of mothers stating that their breastfeeding challenges were resolved post-clinic visit. Not out of the 40 babies required readmission to the hospital with feeding related issues, and then that gave less burden on the acute services, and we'd also had an extremely low DNA rate of 2.9%, which shows that parents highly value the service. And I think sometimes the first appointment is at 8 o'clock or 8:30, and they're there, they're so happy to come. So effects on the organisation then. So at its core, Launch Care focuses on establishing programmes of work to move to a community-led model, providing local populations with access to a comprehensive range of non-acute services at every stage of their lives. Then the HICWA National Maternity Experience Survey in 2020 highlighted improvements of postnatal services as a service need. And this is because mothers are older, they have increasing complex health needs, and they've been identified, increasing complex health needs have been identified for them and their babies. And these women require more supports from healthcare professionals in both the acute and community settings. And it's found that when women can access the right care at the right time in the right place, they feel empowered, listened to, and safe. Now, so here's some statistical summaries there for the whole year of 2022 to 2023. So we've breastfeeding initiation rates at Galway University Hospital was 70%, and exclusively breastfeeding on discharge was 41.1%, and then non-exclusive breastfeeding on discharge was 23%. So when you add them up, there's 64.5%. And then just our Well Baby Breastfeeding Clinic seeing 268 mothers in a 12-month period, and 121 tongue tie releases were performed, which was 45% of all babies seen. Breastfeeding, sorry, there's a box in my way there. Yeah, so breastfeeding statistics for community care, quarter 1 to quarter 4, and 22 to 23 again. So it went from 26% to 40%, so that's an increase in 14%, and percentage of babies breastfed exclusively a 3-month PHN visit went from 21 to 23. And again, that was just, we were still in COVID then, so our rates now are improving still, so thank God. And that's just the baby seen in the tongue tie clinic. So the future of our clinic, so transferability. So the clinic is in the process of being rolled out within the other Sailta Group hospitals and community care centres along the western seaboard there, up as far as Donegal, and Dr. Ethel Ryan, paediatrician, is governing that steering committee. So this is something, yeah, that can be emulated in other areas quite easily between the hospital and community. Education and training. The clinic supports further training of staff as well as student public health nurses, RGNs, RMs and GPs. So delighted to say since the clinic started, we have a few public health nurses who are doing the lactation consultant exams and the course, and also those who are interested in becoming tongue-tie practitioners can also link in with the doctor there, and she's very open to training people as well. And also we've been looking at advanced treatments. So the clinic is keeping up to date. Staff are currently training in specialist laser and therapeutic ultrasound for the treatment of mastitis, lymphedema and cracked nipples. So improved health outcomes is another benefit. So reduction on the burden of acute healthcare with less hospital presentations and admissions. It enables access to the right care at the right time in the right place. There's collaboration. It's a lovely example how the different specialities can deliver a service that is efficient and effective, and it is enhancing community care. And future generations, as children see their mothers breastfeeding, it will make breastfeeding the norm, which will have a positive health benefit for generations to come regarding reduced obesity and obesity-related illnesses, reduced incidences of cardiovascular disease. So performance achievement principles for the clinic are achieving the right objective, so providing a HSE community breastfeeding clinic for mothers and babies, and it's governed by public health nursing and neonatology, achieving it in the right way based on a local health centre in an appropriate space, which normalises breastfeeding in a more relaxed setting and is non-acute. And achieving it with the right skills. So it's having qualified and registered lactation consultants, tongue-tie practitioners, public health nurses, and registered midwives that work in the community. So this is us at the Irish Healthcare Centre Awards. A couple of months ago, we won 2 awards on the night, which was amazing. So we were delighted with ourselves. So we won Outpatient Initiative of the Year and Clinical Team of the Year. And then we were also put forward by a mother actually for a Friends of Breastfeeding Award in 2023. We were finalists for Initiative of the Year. And also in CHO2, so Galway, Mayo and Roscommon, we were put forward for Staff Recognition Award. We were finalists for that for the clinic. And yeah, as Gillian said earlier, I was up in Dublin on Tuesday in front of a judging panel. Myself and Dr. Ethel and Dr. Schneid, we gave a presentation and we were questioned on our clinic, and we are in the finalist category for right care, right time, right place, and the results are announced in November 2023. So there was 800 entrants for that. 50 got through, so we were one of the 50, and then there's 5 categories, so there's 10 people in each category. So fingers crossed we'll win. And there's some references from today. The Bonya-Baha study is definitely worth looking up, as well as the other studies that I'm sure you're aware of. And thank you for listening, and questions welcome.
No, thank you very much, everyone, for joining us today. We're delighted to see that over 370 people have registered to the webinar today, and some people can listen live to us. At one stage, we had 156 people live on the webinar today, and many people will listen in their own time because they are working and can't commit to 2 hours during the day. So we really appreciate your support, and we look forward to seeing you all again next year. And please do contact us, like Gillian said, with any topics that you'd like us to include in our yearly webinars. And it's great to have that update from Laura in relation to what's happening in Ireland. Thank you, Laura, for that. And it's wonderful to hear of work that's happening all around Ireland. Margaret in Dundalk, Marie in Tipperary, and Ailish in Galway. Thank you so much, everybody.